Good afternoon, everyone. Thank you for joining us at the final NCRED webinar for 2025. Today we're talking about next steps in prescription stimulants as a treatment for methamphetamine use disorder, some clinical implications of the LiMA trial. But before we begin, I'd like to acknowledge the traditional owners of the land we're all joining from across Australia and from where the LiMA trial was conducted. I'm joining you from Darawal land, and the LiMA study was conducted on the unceded lands of the Gadigal people of the Eora Nation, the Awabakal and Warramai peoples, the Darug people, the Bunurong and Wurundjeri peoples, and the Kaurna people. I pay my respects to elders past and present. So today we have a presentation from Professor Nadine Ezard on the findings of the trial, followed by a panel where we hope to discuss more about what the findings might mean going forward. So I'll bring in Nadine now. Professor Nadine Ezard is the director of NCRED. Nadine is also the clinical director of the Alcohol and Drug Service at St Vincent's Hospital, Sydney, which is home to one of New South Wales' first specialist stimulant treatment programs. Thank you, Nadine.
Thank you. Thanks, Lucy. Thanks to our panellists who are online, and we will meet them after I've done my presentation. I'm going to just do a brief presentation on the findings of the lisdexamfetamine for methamphetamine dependence trial that we conducted across a range of sites in Australia. Please feel free to ask your questions at any time. You can pop your questions in the chat. We can either do them real time when you put them in as I'm going, if there's any sort of clarification you want to ask, and then we'll be able to have time at the end to talk a bit more about what it means. I just want to acknowledge my co-authors on this project and note that Nick Lintzeris, who is with us today on the panel, is the senior author on the project when it all got initiated way back in 2014. And just noticing that it was mainly funded by the National Health and Medical Research Council, but also additional funding from St Vincent's Curran and Inclusive Health Funds, Edith Collar Centre and Big Health. NCRED itself is funded by the Australian Government of Health, Disability and Ageing. I'm employed by St Vincent's into New South Wales Health and have competitive research funding from the government, but I have no commercial conflicts to declare. As Lucy's already acknowledged, the work was conducted on unceded lands of the Gadigal people, the Awabakal and Warramai peoples, Bunurong and Wurundjeri peoples, and the Kaurna people. I also want to acknowledge the contribution of people with lived and living experience to this project. So the participants in the trial, also the anonymous client who suggested studying lisdexamfetamine for methamphetamine dependence. So this was when this drug was first launched in Australia for the treatment of attention deficit hyperactivity disorder. And the client said it would address some of the problems that client was experiencing with dexamphetamine, in that had a slower onset of action and a more predictable onset and duration of action than the immediate release dexamphetamine that we were using together. That I was prescribing to this participant. And I want to acknowledge the contribution of people with lived and living experience to the knowledge, wisdom and altruism through research that we are embarking on together. Thanks to the study nurses and research team members, and also to Ni Fung in memoriam. Just as a quick reminder to everyone that methamphetamine use disorder, or what was called methamphetamine dependence. So since the trial was started, we've used a new version of the most commonly used classificatory system, the Diagnostic and Statistical Manual, the American Psychological Association, used to call it dependence, and then they changed that system so that you have a spectrum of disorder from mild to moderate to severe. And severe use disorder really maps onto dependence. So it includes some of those things around loss of control and increasing salience and tolerance and withdrawal, and all of those features that also map onto dependence. So they're just different classificatory systems. So the trial was called dependence using the other classificatory system that we use widely, the International Classification of Diseases, that comes out of the World Health Organization, is also the basis for our funding in Australia, the way that activity-based funding is allocated. That still causes dependence, and that's what we chose for this trial. But just to notice that when you look across other research that's now talking about use disorder, it does very much map onto the same kind of cluster of symptoms that people are experiencing. So it's estimated to be around 10 per 10,000 population, so around 7 million people with that severe disorder or dependence. These data really quite old. They're getting on to almost 10 years old. So we have seen a spread of methamphetamine use around the world, and it's reaching many more different countries and locations than it used to. And we are seeing methamphetamine use disorder increase in North America and some European countries as well. We still, according to this data, have some of the highest prevalence of methamphetamine dependence in Australia, around 7 times the global average. Again, the data could be updated and also does depend a little bit on the reporting quality, and we're pretty good at reporting. But even having said that, it's probably a real underestimate of the actual number of people who are experiencing a disordered use of methamphetamine. By way of background, we know that psychosocial interventions for methamphetamine have some degree of effectiveness. And when you look at the data across all the different trials, there's really not much difference between the different sorts of psychosocial interventions. So the one that's studied most is contingency management, and mostly done in the US context where people are actually paid for or have a prize draw for a urine drug screen that is negative for methamphetamine. And those urine drug screens in the early studies were done 3 times a week and supervised. So that kind of intervention is not translatable to the Australian setting, but that kind of intervention has been studied most. But the other kind of interventions like cognitive behavioural therapy or motivational interviewing or any of those kind of psychosocial interventions, when you look across all of it through the systematic review that was published in the Cochrane, they all are pretty much the same effectiveness. The effectiveness doesn't really keep going when people stop engaging in the treatment. And for people that are using frequently, so every second day or at least 16 out of 30 days in the month, those treatments are really not so effective. So we don't have much to offer people that have really severe use disorder that are using frequently. And in contrast to other substance use disorders like opiate use disorder, there's no approved medication. We look at a class of kind of treatment approaches called agonist medications. They have a similar property to the drug or the substance that people are trying to change their relationship with. So for very pure agonists like opioid use disorder, those agonists will be acting on the opioid receptor in the brain. But we're also arguing that these are stimulant medications, so they have a very similar stimulant-like effect to the stimulant that people are using, but they can be given at a safer dose, safer route of administration potentially, with fewer adverse effects, and they're a pharmaceutical grade product, so there's more reliable active ingredient in each of the doses. And we are drawing from the evidence of other drug use disorders like nicotine replacement therapy for someone who's smoking cigarettes, or like methadone or buprenorphine for people that are changing their relationship with heroin or some of the other opioids. The theory is that not only does it provide a framework for regular healthcare and psychosocial intervention, so if you're already going along to a health service, then maybe you can get other services from them, get, for example, Hep C tested and treated, or have your high blood pressure managed, but also it attenuates the negative reinforcing effects. So someone that's using because they're experiencing withdrawal symptoms, so particularly for methamphetamine, people feel very fatigued and have brain fog, so that then drives someone to keep using again, that having the stimulant on board, then that will prevent that drive to use to treat those withdrawal symptoms. And then the other theoretical contribution is that if you're taking a high dose stimulant every single day, then if you use on top, then there's not so many positive reinforcing effects, so you don't feel as high, so that doesn't then reinforce continued use. I'm not sure that logic has been borne out in the data, and it's probably more that's about attenuating the negative reinforcing effect or treating the withdrawal syndrome. So lisdexamfetamine, as I mentioned earlier, has been approved in Australia and many other countries for the treatment of attention deficit hyperactivity disorder, and also more recently to binge eating disorder to a maximum of 70 milligrams. And it's actually in the Australian context, we are seeing an increasing number of prescriptions of lisdexamfetamine for the treatment of those two disorders, to the point where we have around 200,000 people last year reporting using methamphetamine, and around 400,000 people prescribed lisdexamfetamine. So just to put it in context, it's quite a widely used medication, but it only goes to 70 milligrams. It's a prodrug of dexamphetamine, so that means it's hydrolyzed into the inactive lysine component and the active dexamphetamine component in the red blood cells. that process of hydrolyzation is time dependent. So even if you crush it up and inject it, it's not going to have a more rapid onset of action. And so from that respect, policymakers might be more willing to have less close supervision of the medication if they are afraid of intravenous use of a prescribed medication. Also, when people, and it also does bear out when you ask people, do you like it? And people don't really like it when they inject it. It's a once daily medication, has a slow onset, longer peak concentration, and longer duration of action than the immediate release dexamphetamine that we have available in Australia. In other countries, you can get a sustained release preparation, but we don't have that. So because using 70 milligrams of lisdexamfetamine in someone who's regularly using methamphetamine is probably going to be an inadequate dose, we needed to pilot it up to a higher dose to see if it was going to be safe in people that were also using methamphetamine. So we did that pilot. We went up to 250 milligrams, which is about equivalent to the dose of dexamphetamine that we were using clinically, which is 80 milligrams prior to that. And it seemed like people were there were no safety concerns, and we got a few effectiveness signals in terms of people reducing their use. So then we went on to do a formal multi-centre randomised control trial of 12 weeks of 250 milligrams daily versus placebo. And the primary outcome we were looking at was reduction in days of use. We know that there's a good association between improvements in health and well-being associated with reducing days of use. So that was our primary outcome measure. We weren't testing we were looking for signals of effectiveness of the drug. We weren't going to conclude from this study how long people should be on the medication or how to taper off the medication. So we went up in 1 week, people got 12 weeks, and then they came off very quickly. Those other questions about duration and taper, they have to be answered separately by other studies, but this was just to see if there was a signal for that 250 milligrams. It was randomised 1-to-1, so people had a 50% chance of getting the medication. Neither the participants nor the researchers nor the clinicians knew which arm people were randomised to. We did ask people to guess what they were randomised to. It was done in 6 clinics over 2018 to 2021 in Adelaide, Melbourne, Newcastle and Sydney. You will see from those dates that it did overlap with the COVID-19 pandemic and the public health response to that, and that did impact on the trial. So that's just a caveat that we need to take into account. And people had to be not only dependent on methamphetamine, according to the International Classification of Disease criteria that I mentioned, but also they need to report at least 14 days use out of the previous 28, because we were really looking at trying to find something to offer that group of people that we had very little to offer. As I said, it was 12 weeks of 250 milligrams a day. We inducted people quite rapidly, so starting at 150 milligrams based on our pilot data, and then reduced over 2 weeks. People were also offered, because there is some evidence of effectiveness for psychosocial interventions, and the one that we have most evidence for that's relevant to the Australian context is cognitive behavioural therapy. So we used the Amanda Baker manualised 4 sessions cognitive behavioural therapy intervention, so that all the sites were offering the same thing, but it wasn't compulsory. People were just offered it. As I said, people randomised 1-1 to either the lisdexamfetamine or the placebo, which was identical in look and appearance. And the study visits on the first week to check for safety concerns. Initially, we asked people to come every day for 5 days. Once the COVID pandemic hit, we changed the protocol so that we decreased the kind of amount of contact people had to do. And also by that stage, we hadn't really seen any safety signals. So we reduced that to just the first 2 days that people need to come in, and that next 3 days they were followed up by phone to see if they had any issues. During the 12 weeks maintenance period, initially people came in twice a week for supervised medication, and they got takeaway doses for the others days, and then they came back with the pills that they hadn't taken and had some adherence counselling if they weren't taking all the pills. And at each of those 2 visits, we took a urine drug screen, and then one of those was selected at random for testing. The reason that we only tested one was simply financial. We didn't have budget to pay both of them. So after the COVID pandemic measures, we reduced that also to once a week. So we just had once a week screen and once a week supervised dosing. People had long visits and medical review at weeks 1, so baseline, week 5, 9, 13, which is the primary endpoint, and then follow up to week 19. And people got reimbursed according to the scales that were the kind of reimbursement that was standard at that time. I know that reimbursement in today's context is probably more than that, but people could be reimbursed up to $290 each. So the primary outcome measure, and this is important, so the primary outcome measure is self-reported days of methamphetamine use using the timeline follow-back method, which is like, what did you do yesterday? Did you have a birthday? Did you, in the last 28 days, what were the significant things? And then getting people to look back. There's pretty good evidence that self-report data is valid, particularly if there's no negative outcomes associated with it. But obviously there's recall bias. So, ask yourself if you remember what you did 28 days ago. But that's considered the best kind of measure that we have in this setting at the moment. We can talk later about some other measures that we might be able to use going forward. But the primary measure was just the past 28 days. So if people have 12 weeks of medication, you're just talking about that last 4 weeks of medication. So that's the primary. We also had other methamphetamine use outcomes over the 12 weeks. So one of them was methamphetamine use over the entire 12 weeks. The other was the longest period of self-reported abstinence, 21-day abstinence, which is a standard measure that they use in many studies, particularly from the United States, methamphetamine negative tests, and then things like retention, craving, satisfaction, use of other substances, and also, of course, adverse events rate. It's very important. You won't be able to I don't think you'll be able to see the flow chart, but in summary, we randomised 164 people. Of those, 155 received at least one dose. So there were a number of people that just didn't turn up for that first dose. And of those, 100 were retained to week 13, of whom 89 were still taking the medication. So you can see that's not by no means 100% retention, and I'll mention that later in the findings. So the age, you can see that the average age was around 39, which kind of is consistent with our treatment populations. 38% identified as women, which again, it reflects our treatment populations. That may not reflect the actual population of people who are running into issues with their methamphetamine use, but certainly reflects our treatment populations. The 20% of the population were educated to university, but almost half had finished by year 10. 20% were in full-time work. The average days of methamphetamine use at baseline was 24. Importantly, almost 40% of the sample screened positive for symptoms of childhood ADHD using the Wenber-Utah rating scale. It's a 26-item test that asks about things when you're a child at around age 11. So not asking about current symptoms, but asking about retrospective, but just the participants, so no attempt to actually diagnose ADHD. But around 40% of people actually screened positive, which is we know in treatment populations for substance use disorders there is an overrepresentation of people with ADHD, but certainly greater than the general population. And around 50% had any injecting use, and most people were fairly highly dependent. So this is the results chart, as you can see. So if you look at the figure, the line at the top is the placebo, so the inactive medication, and then the line at the bottom is the active medication, lisdexamfetamine. And you can see that both groups decreased, but the lisdexamfetamine group decreased by a greater amount than the placebo group. And in the predetermined primary outcome, which was the last 28 days, there were around 2 days fewer use out of 28 in the active group than the placebo group, but that's very weak evidence. As you can see, the confidence intervals overlap quite a lot. When you look at the secondary outcome, which was across the 84 days, so I don't know if you can see my pointer here, but so from week 5 to week 13, there were around 9 days fewer use in the lisdexamfetamine group than the placebo group, and that reduction happened quite early, as you can see. So, and that reduction is a greater than 30% reduction compared with baseline, and there's some evidence that that's clinically significant. We can talk about that later as well. Importantly, there were no serious safety concerns at this dose in a population using stimulants. Most adverse events were mild to moderate. There was a difference between the groups with people experiencing nausea. There were 4 participants who experienced serious adverse events in the active group and 3 in the placebo group. None of them were we considered to be directly related to the medication in this setting. The blood pressure and heart rate, there were no between group differences. The only thing we could find was there was a slightly higher diastolic blood pressure in the lisdexamfetamine group at weeks 5 and 8. And we do know, obviously, that high-dose stimulants do have blood pressure effects. So that's not unexpected, and also interesting that there wasn't really much difference between the 2 groups. There was no difference in retention between the 2 groups. Again, the lisdexamfetamine group is the yellow one at the top, and the placebo group's the green one at the bottom, and so that wasn't any different between the 2 groups. The other outcomes that were important is that there was greater self-reported treatment effectiveness in the lisdexamfetamine group and greater treatment satisfaction in the lisdexamfetamine group. So even though people were randomised, the group that got the lisdexamfetamine felt more satisfied and felt the medication was more effective than the placebo group. And that's an important participant or person-reported outcome measure to take into account. The other thing that was interesting is that this was not a group of people that were coming for counselling. There was a mean of 1 session attended per participant and no difference between the 2 groups. There were no other significant findings. As I mentioned, the study was interrupted by COVID, and this did actually interfere with the retention and the final data collection. So as you can see, 57% retention with no difference between groups, the overall retention. That's less than what we would hope for a trial like this. So the publishers of the journal, that the findings were published in, asked us to do a post hoc power analysis. Then it came out to 65% powered to between group difference of 4.5 days on the primary outcome. So this study, like many studies before it, is plagued by low retention in the study. So this is no different to any other study, and that's something we need to think about going forward. But obviously COVID had something to do with that. The other thing that some reviewers or people interpreting might say is that the primary outcome was self-reported days of use. We do defend that, but that is certainly something that some perhaps policymakers might find unconvincing. The other thing is that the lisdexamfetamine group was slightly more likely to guess that they were allocated to the active group than the placebo group, guessing that they're allocated to the placebo group. So it wasn't perfectly blinded in that sense, and whether that biased people's interpretation of whether they thought the medication was effective. So from this, we can conclude that lisdexamfetamine led to a reduction in days of methamphetamine use over a 12-week period, but only very weak evidence that this was maintained during the last 4 weeks. So for me, that has a practice implication, is that if someone is receiving lisdexamfetamine for the treatment of methamphetamine use disorder, that you would hope to see change in use within the first 4 to 8 weeks. And if you're not, then you would need to reflect about whether there's some other treatment options that should be explored. But I do think the findings are consistent with recent guidelines that have been released from the United States by the American Society of Addiction Medicine and the American Academy of Addiction Psychiatrists, where they recommend off-label psychostimulant prescription for stimulant use disorder by a specialist clinician and very closely monitored in terms of both the side effects, because we know this medication can cause psychosis and can cause high blood pressure. That's just one of the things we know about the medication, so people do need to be closely monitored. What we can conclude is that lisdexamfetamine at higher doses than approved for other indications like ADHD and binge eating disorder appears well tolerated and liked. I think in the future we do need to stratify by childhood ADHD status. We weren't powered to detect a difference, and so there wasn't a difference in our sample, but we weren't powered to detect a difference. So that is something that to be considered for future research. And the other thing is having really harmonise measures on what a clinically meaningful outcome is, because there are many studies of treatments for stimulant use disorder, and they all use different outcomes, and some of those outcomes are potentially not so clinically meaningful. So finding a threshold of reduction in days of use that we agree on, or having a mixed composite measure that includes participant-reported outcome measures or includes health and wellbeing measures, that's a discussion that we need to have. And I know that the Dutch Medications Agency now, when people are asking to study a drug, they do need to have incorporated in that some kind of health and wellbeing and participant-reported outcome measure in their primary outcome. There's the paper if you want to read it, or if you want to get in touch with me, I can send it through to you. It's free online access for people. And thank you to you for listening and for all the people involved in the trial. And now we can take some questions.
Thank you, Nadine. Yes, as Nadine said, if you've got any questions, please pop them in the Q&A box. We really want to talk about sort of what this means and what some of the next steps might be, but if you've got any specific questions about the study, we can of course answer those as well. So I'll introduce all the panelists and ask them to turn their cameras on so that we can have a bit of a discussion. I'm going to be moderating the panel today. I'm Lucy. I'm the Knowledge Translation Lead at NCRED. And on the panel, we have Professor Nick Lintzeris, who's an addiction medicine specialist who has been involved for over 2 decades in clinical service delivery, research, professional education, and policy activities in the field. He's internationally recognized as an expert in the treatment of opioid dependence and has research interests in benzos, cannabis, and psychostimulant use. Nick's the Senior Staff Specialist at South East Sydney Local Health District and the Conjoint Professor in the Division of Addiction Medicine, the Faculty of Medicine and Health at the University of Sydney. We also have Dr. Liz Nock. Liz is a Senior Clinical Psychologist and currently the Allied Health Clinical Lead for the Alcohol and Drug Service at St Vincent's, Sydney. She has over 15 years' experience working in substance use treatment in both clinical and research settings in Australia and the UK. Liz first began work in the field in the initial pilot of the stimulant treatment program and continues to have a particular interest in treatment of methamphetamine use disorder. As a 2020 NCRED clinical scholar, she developed and delivered the SIMA trial, a pilot study of psilocybin-assisted psychotherapy for methamphetamine use disorder, acting as investigator and lead therapist. And finally on the panel, we have Adrian Tait. Adrian is part of the Lived and Living Experience workforce at St Vincent's Hospital. As a card-carrying queer, he's passionate about social justice, equity, and respecting other people's autonomy and Kylie Minogue. Same, Adrian. Adrian has a background in support work, counselling, cultural studies, customer service, and taking too many drugs. So, thanks for joining us, everyone. I'm hoping we can have a really rich discussion today. My first question will sort of direct to Liz and Nick first, but then also we'll get Adrian to jump in as well. So as Nadine said, the study suggests that experienced clinicians could consider off-label prescription of lisdexamfetamine to clients with close monitoring of risks and benefits. So what sorts of things would a clinician need to consider before doing this?
I'll jump in, Lucy. Thank you.
First?
Yeah, thanks, Nick. Look, I guess this is an interesting question because it's somewhat aspirational and wondering what we could consider, but at the same time, my answer to this question comes from my experience, being a part of a service that does prescribe occasionally these sorts of medications, in the case of STP, dexamphetamine, off-label. And so, very much not, I guess, my experience sort of from a research base, but just from those individual occasions where we have done this. What do we need to consider? Look, I think first and foremost, the capacity to deliver psychosocial supports of various forms alongside are really essential. I think that's because, so that leads into the next point, we really need to have a very solid formulation as a clinician of, what are the driving factors, what's keeping methamphetamine use disorder going, what's making it hard to stop. And that's because I suppose we have a sense that if, a drug like dexamphetamine or lisdexamfetamine works the way we sort of hope it might, it might sort of help with that one component, as Nadine sort of said, the prolonged withdrawal, which is obviously such a huge driver for sort of returning to use, but it is still only one of the, a number of drivers, I suppose, of why it's so difficult to often completely stop or reduce methamphetamine use. And so a really thorough understanding of, sort of individual's formulation is really important prior to sort of thinking about this sort of thing. I guess it goes without saying that monitoring is important. I think partly from the support aspects that come with psychosocial support, but also, I would agree with Nadine's comment that from my experience, I think it's sort of not necessarily so likely that one of the benefits is that there's sort of a reduction in the benefit of using on top of dexamphetamine or lisdexamfetamine. And so, we really do want to be cautious of the potential to risk essentially doubling up on sort of a high dose stimulant because there's inevitably increased risks associated with that. Look, I could talk for a long time and I won't. I think understanding the goals of why you might be sort of embarking on a treatment of this type are essential. Like, what's the endpoint? That's that clinically sort of relevant, sort of effective outcomes. Are we looking at sort of a complete stop, a reduction? Are we looking at harm reduction sort of strategies, that sort of thing? I guess these are all the things we want to think about essentially before even considering embarking on something like this, which is still very rarely done. Obviously is really important to say. Yeah, I'm sure I'll think of more. Also, the only other thing that's important to mention would be that the monitoring again comes into the fact that this, I would not view this as a sort of a longer term substitution medication. And so I guess, being conscious of what sort of a reduction or what your goals might be in that space, what that would look like, really important sort of precursor to thinking about this sort of thing as well.
Can I chip in? So I'm going to couch this in the framework of evidence-based medicine. Because evidence-based medicine is supposed to be the framework in which we deliver all healthcare. However, I also want to challenge what a common misunderstanding and misconception about what evidence-based medicine is. So when evidence-based medicine was originally conceptualized in the 1980s, it was done by a group of clinicians, cardiologists actually, who were looking at all these procedures that cardiothoracic surgeons, often surgeons, were doing for which there was no evidence for. A little bit like recent, reviews of medical practice in Australia, where they go and look at things like, why are we doing all these knee laparoscopies? Millions of dollars being spent on knee laparoscopies, yet there's no evidence that they impact on anything other than make the orthopedic surgeons and the insurance companies much wealthier. That's pretty much appears to be the only outcome. So when evidence-based medicine was first introduced, it was very much this idea of we can't leave it up to clinicians and patients to determine solely leaving it up to them to determine how healthcare is delivered, given that actually there's a public purse issue. We all have a stake because we're all paying through our taxes, and there's equity issues and so forth. So they introduced this idea of evidence-based medicine needs to be the harmonization of what evidence from randomized controlled trials, and not just randomized controlled trials, but what the evidence tells us. And there is a hierarchy of evidence, and randomized trials are the best forms of evidence. And if you've got multiple randomized controlled trials, you can even do a meta-analysis, pull them all together and see what the pool shows. But if you haven't got a lot of RCTs, then there's other forms of evidence. Not as strong, not as convincing, but there's still evidence. That could be a case series. It could be an individual case report. It could be the experience of patients, the experience of clinicians. So that all adds up to evidence, just different levels of evidence. And the research is really important. The evidence is really important. And however, evidence-based medicine is not just the application of a bunch of we implement what the randomized trials tell us. That is complete bastardization of what evidence-based medicine is. Evidence-based medicine is a trilogy between what the evidence tells you, between what the patient factors are, like what's the patient prepared to accept, what are they willing to go along with, as well as individual issues around patients. So some patients, for example, say with amphetamine prescribing, if you've got a history of severe hypertension, well, you may not be the best person to be whacking on 300 milligrams of lisdex a day because it's, side effects. So lots of factors will impact upon what we mean by patient factors. Patient choice is a big one, but there's other kinds of, individual things like biological and psychological profiles. Also then is the issue of logistics for patients. What can patients afford? Big factor. The third part of the trilogy is clinician or service provider factors. So that then gets down to what are clinicians and service providers prepared to do. Some of that will be linked to funding. We're not funded to do this, or we are funded to do it. Some of it will relate to things like governance. So if you work for a government organisation, say in New South Wales Health or Queensland Health, you've got to comply with your government's organisation's policies, procedures. So, for example, those who don't know about working in a government service, we aren't allowed to prescribe a medication unless it's on the formulary. So there's all those funny little factors. And on top of all that then is the experience of the clinician. So what a GP, inexperienced in providing treatment to people with methamphetamine use, is prepared to do or should do might be very different to, say, Nadine, Ezard, or an addiction psychiatrist who's been working in this space. So none of these are givens. None of these are fixed factors. They're all moving. So that gets us back to, should we be using lisdexamfetamines to treat people with methamphetamine use disorder? And I would say, well, you've got to explore each of those three dimensions of evidence-based practice. For the right clinician and the right patient, the evidence is more than adequate. For the wrong patient and the wrong clinician, this evidence does not stack up. Now, that might sound weird that I'm saying evidence should be interpreted according to individual patients and individual clinicians. What, isn't it something just an academic can do, sitting at a computer? And the answer is no. An academic, all they can do is meta-analyses. Application of evidence-based medicine is very much about the patient and the clinician interpreting the evidence. So could we be doing lisdexamfetamine? Absolutely. The right clinician and the right patient. Based on what we've heard, I kind of go along with the idea of what the Americans are suggesting, and our evidence from this data would suggest there is a weak signal here. For some patients, it clearly had an effect. When you see an average reduction of around 9 days in about 80, that's an average reduction. It means for some patients, there was a much stronger effect. For other patients, there would have been no effect whatsoever. So the medication clearly can work. We've got evidence of safety. And so I would back it up for the patient that is not willing, unable to access, for example, private treatment, or unwilling to pay the gap fee for private psychologists at $50 to $100 a session, can't afford to see an addiction psychiatrist in private, $600 a pop. So for some patients, conventional treatment is just not inaccessible, or they've done it and it doesn't work. Similarly, there will be some clinicians that feel, I can do this. And if you're a private clinician, much easier to do than in public. But, we're starting to get into nuances. So overall, I would suggest this is definitely within scope for evidence-based medicine for the right patient and the right clinician.
Thanks, Nick. Yeah, I think it's a really interesting way. So it's like, yes, if it's the right people and the right context. And so maybe I'll just throw to Adrian briefly here. Like from a sort of client perspective or a lived experience perspective, we sort of talked a little bit in there about, the need for psychosocial support, the need for it to be affordable, or if you can make it to a psychiatrist appointment, all those other things. What else do you think could affect whether this could be a good treatment for clients? and what would make someone attracted to this kind of treatment or not?
Oh, I don't know. That's giant, isn't it? I think I meant to know the answer to that. I think I will leave it to the medical aid people as to the kind of a lot of the intricacies around what. Yeah, I mean, it sounds exciting. I think one thing that jumped out to me was Nadine mentioned that, changing the relationships to a substance. I think that was a sentence. And I think outside of a purely kind of easily quantified data medical lens, changing a substance, obviously isn't. It's not an objective fact. It's a really complicated thing, and I think changing relationships with, this has implications. Changing relationship with healthcare in general, with engagement, and with suffering as well, because there's now an element of suffering that comes with when you stop meth. It's bloody awful. And I think what Nick was saying as well, obviously there's socioeconomic considerations around this and equitable access to care. A pretty giant and complicated. And I think the ADHD stuff is very interesting. Don't know. I don't know if I'm just saying that because I'm poor and I've got ADHD.
Can I add the discussion around access to psychosocial? I'm not as convinced as Liz that this is something we need to put as a mandatory add-on or else don't do this treatment. Clearly, you can see from the study, most patients were not interested, did not avail themselves in counselling. And I'm also just kind of like, can we learn from the experiences of where we ended up with, say, nicotine replacement or opioid treatment? In the early days, methadone treatment, I'm talking about 50 years ago, 40 years ago, methadone treatment could only be offered for people that had failed conventional treatment at least twice. It could only be offered in a time-limited way, up to 6 months in many programs. In some of the American programs, it was a 2-year maximum cutoff. At 2 years, you had to come off it. And they also used to mandate, and you have to do counselling. And if you don't turn up to counselling, we kick you off the program. Now, none of that was done. None of that was put in place, one, because the evidence supported it. It was just what we thought was important in treating patients with drug use issues because we knew best. We knew that counselling was important. We knew supervising every dose was important. We knew all this. It turns out none of it was. It turns out methadone treatment works really fine even if you don't do a lot of counselling. And more importantly, I don't know a lot of clients who turn up to methadone programs or buprenorphine programs and engage in a lot of counselling early on in treatment. And what they want from treatment early in treatment and their goals often is very different. If they're still in treatment a year later and you come back and are talking to them, then patient goals change, willingness to participate in things like counselling change. So I wouldn't get too hung up about us thinking that we know what's best, because we don't always. And there's nothing to suggest from the data thus far that making counselling mandatory helps. Certainly should have it available, but I don't think we should be ramming it down people's throats.
Might just jump in, Lucy, and say,
Yeah,
reply. Important, I think, to clarify that I definitely think that the sort of the broad terms of psychosocial support can look like many things. It is not just counselling necessarily, and I guess I use it in that sense of the various things that might support sort of practical change. The aspects of of someone's life that contribute to difficulty making this change otherwise, that a medication is not going to have such an impact on. And that could be, really sort of, it could be sort of understanding within oneself of the change that needs to be made. It might be supports to make practical change. It might be sort of living situations. It might be, avoiding certain people, whatever that is. But it is probably a pretty broad, pretty broad concept when I talk about it like that. Yeah.
Thank you both. I might just jump into some of the questions we've got from the participants. Some of them kind of dive in together, so we can sort of answer a few at once. But we've got a question here about were the results of the study strong enough to consider rolling Lisdex out as a treatment option? Nadine?
I mean, I think that's what we're answering here, isn't it? It's like
Mm,
treatment option for whom and when. And the bigger, Nick made quite a strong statement that for the right client and the right clinician could be the right intervention. When you talk about rolling out, I see that as at a broader scale, and for that we would need to go through all of the other processes that you need. So not only do you need the evidence that's convincing, you also need a drug company that wants to register this drug for this indication, and then you need the government to subsidise that drug for that indication. And those processes cost hundreds of thousands of dollars, even if you do have a drug company that's interested. So there's a lot of other barriers. And the first step is actually to get the convincing evidence. There is enough evidence for some people, I think, for some prescribers to be doing it already within the existing regulatory environments. But that itself is going to be, the regulation and the cost barriers are going to be enormous for most people.
The cost is a big factor, isn't it? I mean, let's be upfront about costs. If you're wanting to use 250 milligrams of Listex a day, and remember, not on PBS, patients got to pay for it out of their pocket because this is not a listed indication. If you've got ADHD, you can get it prescribed for ADHD, but still outside of the dose range. So, you know, ADHD, it's only subsidized up to a certain dose. But I mean, what's the price? What price are we talking about, Nadine, or does anyone know what the over the counter, you know, non-subsidized, so a private script of Listex, it would be in the hundreds of dollars a month, wouldn't it?
Let me look it up. But so on the basis of that, we do have a very cheap, readily available medication, dexamphetamine. So is that the conversation we also need to be having?
And I
And I
think
think,
that's a really important issue. There's two factors. One is just the logistics of treatment. So dexamphetamine treatment is easier to roll out because the medication is so much cheaper. There's no point having a brilliant treatment that no one can afford. Or, you know, only a small number of very rich patients can afford. So dexamphetamine is far easier to logistically provide, but there are some challenges with it. There may also be benefits in dexamphetamine over Listex. Think about it. Listex is a slow onset, slow release, sort of boring drug. Think about it. Most slow release drugs are boring drugs. They're not designed to produce an immediate effect. They're slow onset, slow decay. It's like, you know, it's like methadone. It's not the same as using heroin. It may well be that dexamphetamine, faster onset, more like a standard. It's like more like, you know, popping, you know, a normal. It's like using amphetamines, I guess. That may have certain benefits and certain disadvantages for some patients. So, you know, there are some differences between the meds, and it could well be that dexamphetamine is an easier medication to get going with.
yeah, that's quite good. And I think it's quite interesting. There's quite a few questions in here around, and maybe this kind of talks about both lisdexamfetamine and dexamphetamine, but what are some of the sort of contraindications for this sort of use? And then also that question around ADHD. How do we decide who is the right patient? Are the ADHD tools the right ones to use? Or is it just, would this suit anyone with substance use disorders? And then is it habit forming as well? So some questions really around what it would look like in practice there.
Well, very quick, the last one, just get your head around this. If we're using this to treat someone with an amphetamine dependence, then they already have a habit. So we shouldn't talk about this being habit forming. The question is, does it maintain, you know, a dependence? And the answer is, yeah, very much so. But the nature of the dependence changes. In the same way, if you're on methadone, you still are opiate dependent, but the nature of the dependence is very different to if you're running around injecting heroin. And, in classification systems, you could use language such as, in treatment remission. There's ways of categorizing it. But yeah, people would still be dependent to stimulants if they were using the medication that way. How severe the withdrawal would be and what are the relapse rates on cessation, we don't know. That would be the subject of a lot more research there.
Does anyone else want to jump in there? Liz?
I guess I was just thinking that without knowing any of the answers, that just leads into the questions around that we don't know, sort of as Nick said, around tolerance, but also I think there's a question in the Q&A around sort of why I reference that I might not use as a longer term substitution medication. Again, that is very much my own. It's not a firmly held belief, but again, just I guess it reflects, as does the idea of sort of being dependent on a different stimulant. What is the aim? What is the goal? Are we looking to reduce those negative effects of prolonged withdrawal that we know are so challenging with methamphetamine use disorder, and then what are we looking to do next? So is the goal sort of a gradual wean? Is the hope that while this while the medication is perhaps effective, other things, other components that make relapse likely can also be worked on. So what are we actually working towards, and are we looking to sort of wean gradually? And again, is it, yes, as Nick said, is it easier to do that then? What is the withdrawal effects from a prescribed stimulant? They're sort of the questions that we still don't know, but they do always come back to why do we think this is working and what are we trying to achieve?
What if someone did have ADHD and there was, at the end of a wean, you've reached a little stage where you're like, oh, actually, my life feels better and easier and more manageable. And then we stop the dosing. And then because of a period of time, whether someone was willing to diagnose ADHD or cost around access to meds, are we asking someone to compromise there?
Yeah, Adrian, I agree. It's a challenge. And I've actually had a couple of people that I've been pretty convinced to have ADHD and wanted to stay on the lower doses. And we had to find a psychiatrist that was willing to take over prescribing for the treatment of ADHD, plus the neurocognitive and neuropsychological test that psychiatrists demanded. And it took us a good year or two to actually transfer that person across, plus costs for that individual to see the psychiatrist and the neuro psych assessment. So I totally agree there's an issue there in terms of access.
I mean, I think in many respects we're identifying, the research questions for the next sort of 10 to 20 year research agenda. So the issue around long-term stimulant prescribing. So I think most of us would feel a little bit queasy if you were like keeping people on 250, 300 milligrams of Listex a day or 100 milligrams of dexamphetamine, and you kept that going for years and years and years and years. I think a lot of people would kind of, well, gee, it'd be good to see some safety data there. And what are we doing to people if you're prescribing like that? The flip side is we have got, estimates I saw recently, 400,000 Australians on long-term stimulant medications. So it can't be that dangerous, can it? So this idea about, well, you can't stay on stimulants, well, go tell that to a bunch of kids now that have been on the stimulants for 5 years and are probably going to be on for another 20 years. Some of this is about dose settings. And it's a little bit like sort of saying, let's look at what we do with methadone. We often need 120 milligrams to help a person stop their heroin use, if that's what they want to do. But it doesn't necessarily mean that person needs to stay on 120 milligrams for the next 30 years. And indeed, if you do that, chances are you are contributing to poor health in that patient. You are going to cause problems from being on 120 milligrams of methadone. But not many patients actually need to continue at 120 milligrams. That's the dose they needed to stop or to change. 10 years down the track, many of them can actually just sit on 30 or 40 milligrams, and that's all they need. If they try to stop, they have problems, but they find a low dose. So it may well be that in 10 years' time, once we've got more research and more experience, it may well be that our treatment models are, yeah, you need high doses early on to change relationships, to change patterns of use, to be able to get the person in a position where they're prepared to think about lifestyle changes and psychosocial. So how you construct treatment in the first 3 to 6 months may look very different to what month 6 to month 24 looks like, which may look very different to what happens for months, from the 2nd to 5th year of treatment. So, we shouldn't treatment is not just a black box of fixed stuff that doesn't change. We need to be constantly reevaluating our treatments to match where the individual person's at, the client, and what their goals are, which change over time as well. You hope they change over time. If we're doing our job right, goals change over time.
Yeah, I think that's a really good point. It always comes back to that sort of person-centered care and the specific context of the clinician and of the clients and their goals and what that looks like over the long term. But yeah, Nick, you make a good point. We've got the next 15 to 20 years of research kind of ready to roll out all these questions that still need to be answered. I'm conscious of the time, but does any of the panelists have any more comments about anything that was sort of talked about today with all of the questions we're raising?
The tricky one is the contraindications. I think it's a really important question, and Nadine, would be interested to get your thoughts. Clearly, the big one is someone who's turned up with a history of amphetamine or drug-induced psychosis. 3 years ago, they were in the mental health unit psychotic, or it may have even been 3 months ago. And now you're trying to figure out a treatment plan for them. And would you consider prescribing a stimulant in someone who's had, methamphetamine-induced psychosis? I don't know if you want to pick that ball up, Nadine?
Yeah, I think it's something that we struggle with in a day-to-day basis too. And sometimes we will talk about actually having an antipsychotic at the same time with someone that might be really keen to give the stimulant prescription a go. But if someone is really extremely psychotic at the time they come to seek treatment, it's really, you'd be a pretty brave person to add extra stimulant into that situation. The other issue I think also is the cardiovascular effects and the hypertension. And we know, if you look at some of that data from the US that's showing the opioid-related deaths going down, but the stimulant-related deaths are not going down at the same rate. And they're an older group of people with coexisting cardiovascular disease, probably from the high-dose stimulant use they've been using for a long time. So adding in a high-dose stimulant to someone who already has cardiovascular disease and hypertension is also a risk-benefit that needs discussion. And I would really insist on good cardiac screening, at least effective treatment of hypertension, and an understanding of the risk benefit in that context as well.
Any other final comments from the other panelists?
It just popped into my head around that, if 20 to 40 years of study ahead, I think I would advocate for some qualitative, did I say that right? Don't listen to me, I can't even pronounce it. Research into how we quantify harm, what a relationship to a substance is, going back to Nadine's point around feeling more satisfied. What does that mean? That's pretty complicated.
Yeah, but a fantastic point to end on, because that's it. It's how do we measure the success of any of these things for the person who is living with a methamphetamine use disorder?
And how do we make sure that the measurement is being generated by the client, by any kind of idea of success, that we're always mindful of context in someone's life?
Absolutely. It's 1 o'clock. Thank you everyone for joining us. I hope this was a very interesting discussion for me, and I hope you all found that as well. Look out for some emails. We'll send you the recording around. We'll have some more webinars in 2026. There's a video abstract for this study coming out soon-ish, I hope. And yeah, have a wonderful afternoon and a wonderful end of year. Thanks for coming, everyone.
Thank you.
Thank you all.
Bye.